Hello everyone, this is Chadi Alraies from CVI 2022. With me is Dr. Drew Klein, a friend and a pioneer in peripheral intervention and coronary complexity here from Piedmont Hospital. Drew, always nice to see you.
Good to see you, my friend.
Yeah. So you're going to touch on the clinical part, but
Yeah.
we're going to touch first on a very important topic about disparity in healthcare for patients with CLI.
Absolutely, and thanks for the opportunity. I think it's really the first time I've seen at this meeting a whole section kind of dedicated to this idea. And really the CLI space is one in particular where the disparities in healthcare get really highlighted.
Yeah.
For instance, African American race is its own independent risk factor for PAD just in and of itself.
Right.
So, and I think if we were at Sky, understanding about implicit bias and then understanding about social determinants of health are all really important. And these are all factors that drive into why we're seeing a higher prevalence of PAD and specifically CLI in our population in lower, both lower socioeconomic class, but also more predominantly in our African American population.
Right. So what makes it specifics and about being, by ethnicity by itself being a risk factor? Is it because of lack of screening? We don't discover disease till it's too late, or there is something genetic?
So I don't think there's anything really genetic. I really believe it is a combination of things. When we know about social determinants of health, where you grew up, do you have access? Do you have access to education? Do you have food deserts where they may not have good foods? Did you grow up? I think Feluso Faccaretti, a good friend and truly a pioneer in this realm. The fact that he could go to a town in Mississippi and cut the amputation rate in half just by doing endovascular. So at the hospital, from what I understand, in that small town would just amputate, straight up amputation every single time. So people just went to the hospital and they knew it was amputation. Feluso comes into town, starts an endovascular practice, is saving limbs tremendously. So it's just about you can make a difference, but also understanding that social determinants of health play a factor for what every patient, be it if someone in a major city like Detroit or in Atlanta, maybe they're coming from a culture where it's not looked favorably upon to go to the physician.
Correct.
Or go to the hospital.
Absolutely.
You know, many places, for instance, and I know places outside the United States in third world, sort of really underserved areas, you'd only go to the hospital to die.
Yes.
And so
Right.
I think it's really important to understand what that person in front of you has, and so you don't have an implicit bias against them, and then kind of work through understanding that it's extremely challenging to overcome socioeconomic status, economic, and in addition, education in one lifetime. These are things that propagate generation after generation after generation. And now is really the time. We have to take a step and move forward and address this. And the American Heart Association recently released a national plan for PAD. And I'm looking forward to Sky's on that backing, as is SVS, and I believe SVM. We're really trying to push forward to identify not only our patients that are at particularly high risk, but what can we do about them? How do we address these social determinants of health? And then how do we get access or really involve ourselves in the community? The barbershop study, classic for hypertension, very effective.
Yes.
Within the African American population. Understanding that the barbershops are a great place to be able to work with in that community. We need to get this research out there so that we can make an impact.
Sure. Well, definitely this is knowing that the American Heart Association and other society is pushing for it. That means there's increased awareness, and hopefully that will minimize amputation in the United States. Staying in the PAD, but let's get more technical to the intervention on common femoral artery. We never covered it on any of the videos. We did SFA,
Right.
we did iliac,
Yeah.
but common femoral kind of a tricky one. So tell us what's your...
It is tricky. So our session here was extremely, it was interesting because many people talked about just common femoral being purely a surgical disease, and then many of us will generally be an upfront endovascular approach. So from my side, it really is an endovascular. I think many patients can be straight up endovascular. It just really depends upon your experience. I gave a discussion regarding technical considerations for CFE intervention, and I think the first thing is this is not something you do right out of fellowship, something you do after 3 to 5 years out. Number two, it really is your etiology of what's going on. Is it atherosclerotic, or maybe it's a dissection from perclose, or maybe from an angioceal? You know, if it's a dissection from an iatrogenic injury, usually those patients do just fine. When it's atherosclerotic, it's extremely challenging to deal with, But now with technologies like directional atherectomy, shockwave, lithoplasty, you can really tackle some very challenging stuff. The key thing about CFA intervention is never to compromise flow to the profunda. And that's kind of the take home of anything. It's very similar to the pancreas and abdominal surgery. Don't mess with it. And so in our session, we discussed the Medina classification like we would use for left main, but being in the common femoral. So 1, 0, 0, 1 being in the distal common femoral, 0 being in the profunda, and then the next one being the SFA. And if we look at it like most of us interventionalists look at it, interventional cardiologists, you can really tease out where patients are going to do well. Again, always understanding that you don't want to compromise flow to the profunda. I showed a case where we did directional atherectomy into the profunda, but also down the SFA with 2 embolic protection devices. And I think the key thing in that situation was really being mindful about where your wires were, but also being protective. So you really want to make certain that you're choosing correctly, you have the right experience, you know why you're doing this, especially in, is it claudican or is it a CLI patient? And you're really thoughtful about the presentation.
Stenting, no stenting?
So great question. I think most of the time I try to avoid stenting in the common femoral, mainly because it's such a flexion point. I think we discussed some data regarding Supera. I think if I need a bailout, I'm going Supera 7.5 now with the bigger size. I think that's the way to go inside the common femoral. Now, balloon expandable, if you look back at the TECO trial, which was a randomized control trial between common femoral endarterectomy and endovascular therapy, there's really no difference at 2 years in outcomes, which was pretty impressive. And so I don't see the CFA as a final kind of why we shouldn't be doing this. But again, you gotta know what you're doing, you gotta know why you're doing it, and you gotta be safe about it. I think when it comes to stenting as a bailout, I try not to stent, period, unless I have to, mainly because I want to leave no trace for a potential surgical option. And then second of all, I think no one knows what these things do over a long 5-10 year period of time. And so, but if you got a CLI patient, you need to establish flow. I think that's where I'm more apt to just go ahead and stent. And the Supera stents or maybe perhaps the new biomedics mimic stents might be another option as well.
All right. Well, Drew, thank you so much for your insight.
Thanks, buddy.
On
Appreciate
both on the social determinant of health and access to PAD, as well as on intervention of common femoral.
Great. Thank you so much, Chadi.
Thank you, everybody, for watching. Watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you.